Medical Director, MS Center of Miami, and Chairman of Neurology at FIU Medicine, we have and we welcome Dr. Jeffrey Horstmyer. Thank you.
Yeah, thank you, Stuart, and thanks so much for putting these things together. They're, I think, very well received. So I've been asked to talk about two things. One is MRI, and then a little bit about symptom management as well. All right, so we'll start with MRI, and okay, clinical utilization of MRI. And MRIs are really very important, not only in the diagnosis, but the management of multiple sclerosis. It's one of the best, what we call surrogate markers that we have in terms of evaluating somebody to see if they have multiple sclerosis and to identify those who are progressing in the disease. And there are a number of different types of lesions that we see on an MRI. There's what we call white matter plaques. Well, let me start with the GAD-enhancing lesions. GAD-enhancing lesions, and that's the very first thing that shows up when there's an MS attack. So normally the seal between the blood vessel and between the brain is watertight. I mean, it's a super tight seal. Even water molecules can't pass back and forth. But the very first thing that happens with an MS attack is that barrier between the artery or between the veins and the brain becomes porous. So when you go for an MRI and they inject the gadolinium into your vein, as that gadolinium passes through that area where the vein has become porous, it leaks out. And in that area where it leaks out into the brain, it changes the signal on the MRI. So we see what's called an enhancing lesion. And that's the very first thing that happens that shows up on an MRI in an acute exacerbation. The next thing is T2 lesions. That's when you put on the FLAIR or T2 sequences. I'll show you a couple in a minute. It's when your doctor has probably shown you an MRI and you see these little white spots. Well, those white spots are the plaques or the T2 lesions. And those are, they can go away, but generally when they occur, they stay. They may evolve into what's called a black hole, but typically for years, once those plaques show up, the plaques remain, and it's sort of a footprint as to how much has been happening over the past years. It's sort of the history of what's been happening with the MS in that particular patient. And then the black holes, that's what really contributes to the brain atrophy that we see sometimes with MS. And what happens is the area of inflammation in that plaque area has been so severe that it actually dissolves a little bit of brain tissue in that area. And so on the MRI, it's what we see a hole. It's called a black hole because it's best seen on those sequences where water is black, because it really just when the brain dissolves and it's replaced by water. You know, nature abhors a vacuum, so something has to go in there. And so brain atrophy is related to the black holes, but it also happens in other ways other than just the black holes. And it's another measure of how much injury there has been to the brain from the MS. So one of the things that the treatments affect the best are MRI changes. I mean, out of all the drug trials that have been done, really the thing that responds, out of all the things we can measure in an MS patient, the thing that responds the very best to treatments is MRI activity. And so all of the treatments generally show a very dramatic decrease in the development of new enhancing lesions and new T2 lesions. And so it's a very good surrogate marker. It's interesting though, and this is one of the mysteries of MS, it doesn't necessarily correlate with disability. There's a loose correlation, but there's not an exact correlation. And so there are people who have a lot of lesions that don't have a lot of disease, and there are people who have more severe symptoms who don't have a lot of lesions. So it's just a sort of surrogate marker, an estimate that's useful, but it's not exact. So this is an example of a gadolinium enhancing lesion that you can see right here. And this is what's called a T1 weighted lesion or a sequence, because you can see water is black here. And this is where that gadolinium has leaked out into the brain. In that area where there's inflammation, the veins became leaky, and when they injected the gadolinium, it leaked out into that area. And you can see it didn't leak out into any of the other areas, only in this area. And that's why it lit up. It changed the signal that one gets when one turns on the magnet and turns off the magnet. And so, number of, as it says here on the slide, number of new gadolinium-enhancing lesions is a very strong predictor of future disease activity. So if you see somebody shows up with a new diagnosis of MS or even with an exacerbation, and you see a lot of T2, a lot of gadolinium-enhancing lesions, you really want to think hard about taking, strong action, because it means there's a lot of disease activity going on. These are T2-weighted lesions, and it's, again, this one shows up as well. This is a plaque here, but you can see this isn't a very good example of it, but there's some smaller plaques around here in some other areas as well. And so when we do an MRI, from year to year, we compare. We try to go back and look at the old one, look at the new one, and what we want to know besides the enhancing lesions, are there more white matter lesions, number one, or have the previous white matter lesions increased in size? Both are markers that there's been disease progression. And so that's, on the machine we're going to text you about later, it has new technology. We can actually line up the head year to year in exactly the same position. It has the way of adjusting the machine so that we get equivalent slices year to year, which will make it a lot more accurate and sort of in terms of determining whether there's really been disease progression or not. This is a black hole right here. You can see water equivalent and its water density, and that's sort of the end stage of the lesion. This is a much better shot of, these are these plaques that we mentioned before. This is a FLAIR sequence. You can see all these little white matter lesions. Particularly, they're more common around the ventricles, but they occur everywhere in the brain. And actually, quite a bit of it occurs in the gray matter. It's just that the current MR technology cannot pick up the plaques that's in the gray matter. One of the things we're going to put on our machine is what's called double inversion recovery, which will allow us to pick up maybe 30 or 40% of the cortical white matter lesions that are not being seen now. And this shows just basically a general idea of progression. Up here, here's an exacerbation, et cetera. And then after a number of years, when one gets less of the exacerbations and more of the just sort of dwindles, the progressive, slow progression of increased symptoms. And this shows what an MRI looks like at each of these stages. And you can see, a normal brain in the beginning, a little bit of atrophy here, and a significant amount of atrophy here in the later stages. Not that everyone goes through that. That's a very gross generalization. Or a lot of people have MS for years and years, and that doesn't happen to them. There's a thing called the McDonald criteria, and the McDonald criteria, prior to MRI, the diagnosis of MS was based upon symptoms. Did symptoms come and go? Did somebody have symptoms in one neurological area and then they went away, and then it would come in another neurological area, like they would have blurry vision, and then another time they'd have numbness on the leg, something like that. And that's the way that we would make the diagnosis. It was recurrence of symptoms over time in space. So with the advent of MRI, we found out that we could actually speed up the diagnosis of MS because we could document the progression of disease in time and in space and be able to make a diagnosis sooner. And so that's what the McDonald criteria were created for. It's a series, it's an algorithm where we can look at different aspects of the MRI and make a determination early on, whether or not this is really MS or not, instead of having to wait a year or 2 or 3 before another set of symptoms come. So this is a big advance in terms of diagnosing MS. This is just an image of the optic nerves, and this is using that technology called double inversion recovery. And you can see here a plaque is seen in the optic nerve on the right. In radiology, things are reversed. And so the right is left and left is right. So, and this is the sort of thing you can pick up, which you can't pick up in standard sequences. This gives an idea of the development of MS that people have a normal MRI. I think the study was, if I remember correctly, was like 14 years down the road, that the probability of having multiple sclerosis based upon initial MRI, that if the MRI was normal from the beginning, risk was greatly different than if the MRI was abnormal at the beginning. And it's just another measure of how the MRI helps us in determining, not only what, the diagnosis itself, but the severity of the diagnosis, which helps guide us, how aggressive you want to be on your treatment. There's another similar, just a different way of looking at it, a number of lesions on the MRI at the beginning, and then years later, based upon EDSS. And EDSS is a score of symptoms. So the higher your score, the more symptoms you have. Like this person would be basically, non-ambulatory. This person would be using a walker. This person would be able to walk with minimal difficulty. And you can see that if they had, it makes quite a bit of difference. If they had 0 lesions at baseline, nobody progressed. If they had 1 to 3 lesions, this would be the progression, 31% would progress a little bit, but to an EDSS of 10, nobody would progress. But if somebody had a lot of lesions, more than 10 lesions, then the probability of progressing to these stages was much higher. It's another way of understanding how MRI is useful in diagnosing and managing and deciding on treatments for MS. Okay, medical therapy. What Stu wanted me to talk about was really symptomatic treatment. And symptomatic treatment can be as important, or actually more important in some cases, than actual medications for the prevention of MS. That the medications we have now available for treating the MS itself, for slowing down the disease progression, really only works in the stages that's called relapsing remitting, when the symptoms come and then they go away, and then a year or so later maybe something else comes and goes away, that fluctuating course. If the MS progresses to that steady, slow progression, which is called secondary progression, those medications don't do anything anymore. In the beginning, where there's still a little fluctuation, they have some effect, but later on, when there's really no more fluctuation, the medications don't do anything to the disease, because the disease is actually different than what it was in the beginning. The disease changes, and we don't really have any treatments for that right now, which is the bad news. But the good news is that we have so many new medications coming on the market, and they're going to be now so many choices over the next few years, that the pharmaceutical companies are really not going to invest that much more money into developing new treatments for the relapsing remitting. So now they're going to be, directing their resources more toward trying to first of all understand, what happens in secondary progressive MS, and then once it's better understood, try to interfere with it, try to develop a drug that would somehow affect that progression. So that's the good news. So in those people who are in secondary progressive, obviously symptomatic treatment is way more important. And so, when it comes to symptomatic treatment, we had a great talk earlier tonight about a neurogenic bladder. That's one of the biggest issues. In MS, those who develop the neurogenic bladder, really has a major impact on their lifestyle. So to get those symptomatic treatments correctly, tuned in for that patient, everybody's different. What works for them and what the proper thing to do is, that makes a huge difference in their quality of life. So another issue is spasticity. There are a number of medications on the market that have been, designed for relieving, the rigidity or the spasticity that occurs in MS, and it can be used in other neurological disorders as well. And I'm sure everybody's familiar with baclofen and tizanidine and some of the others. One lesser known one is fentanyl. It's a narcotic patch that actually works very well in some people. I'm sure we could hear some testimonial about that. And then, of course, there's the intrathecal pumps that can be very effective. By taking the baclofen and infusing it directly into the spinal canal, that you get more drug delivery to exactly where you need it, and thereby you have less side effects. So you can really crank it up and get more relaxation from the drug than you can by pill, and at the same time avoid, for those who have taken baclofen, sometimes it can make you a little dizzy or feel a little drowsy or something like that. You can avoid that by doing the direct infusion with a pump. So, and that's the right thing for a few people. Also, a newer treatment on the market that really, it varies from person to person, but can be extremely useful is Ampyra. And you know, those of you there, I'm sure there's some of you in here tonight who have taken it and had a great result, and others who've taken it and haven't noticed too much. But the thing is, it's a pretty benign drug, and there's always you know, there's always a potential that somebody could really have a very good response to it. So it's something that you know, definitely has to be tried on everybody you know, who has difficulty with walking. Obviously, you have to be able to walk some to get any benefit out of it. But you know, it's made the difference in, you know, one report we got was that would allow a woman to be able to walk from one side of her kitchen to the other, which for her was huge. It was huge. And so that's well worth, you know, the experiment, so to speak. So, you know, that's been a treatment that's really been, made a good difference, what we're doing. Fatigue, that's probably the #1 reason why people can't work. It's not that they can't walk or they can't, you know, have problems with vision or something like that. It's that they just have so much fatigue. And for those of you who don't know about this, the fatigue is, you know, for a normal person, normal by this don't have MS, if you get the flu, you know how drained you get with the flu. You just don't want to get out of bed. You don't have any energy. That's the same kind of fatigue that MS patients get, and some of them all the time. And so you know, they'll arrive at work, get out of the car, and walk across the parking lot. By the time they get to the office, they're done. You know, they just don't have any more energy to keep going. So it's a huge issue to try and treat this properly. And you know, we do have some effective treatments on the market that can be very effective, and one just has to, in a, you know, an organized way, you know, try them out with each person, and you know, watch out for any side effects, watch out how it might affect the sleep, et cetera, how it might affect their mood. And there are a lot of things one has to watch, but in general, they're well tolerated, and in general, they're very effective and can make a you know, big difference in quality of life. Cognitive dysfunction, you know, I think that there's no real direct treatment for that. The best thing is using you know, prevent as much as you can, as early as you can. If somebody has a lot of fatigue and you improve the fatigue, generally their cognitive function gets a little better as well, objectively and subjectively. And this, I just happen to have a CSVI slide in here. We don't know what's going to happen here, but and it looks like that it's not a cure-all, but you guys know what I mean by CSVI, right? The venous blockage from the veins draining the brain. And it turns out that the vein strictures occur in other diseases as well. It's not just exclusive to MS. And so there's apparently some connection that's not well understood, but as the cure, clearly not. Is it beneficial in any way? Maybe. If anybody is going to get into this and do the CSVI thing, I would just, you know, highly recommend, just for the benefit of everyone who has MS, to do it in the U.S. as part of a trial, you know, instead of going off to Bolivia or, you know, wherever, and having it done. To have it done here within a trial, so that we can gather the data and use that to answer the question, you know, whether it really does anything or not. So that's it. Thank you.